Hi, this is Dr. Sham, and welcome to my YouTube channel. A very important topic today, that is pulmonary embolism. So, this pulmonary emboli, they arise, for the most part, they arise from the proximal deep vein, the veins above your knee, and in turn, the most proximal these DVTs, they are a consequence of propagation of the distal DVTs. What I mean by that is the below the knee veins. So, from the below the knee, the veins are there, the thrombi are formed there, and they propagate, okay, to the proximal above the knee veins, and then they go to the right heart and then to the lungs. What exceptions are there? That is in the pregnancy. So in the pregnancy, um, these thromboses, okay, this thrombi may occur initially in the pelvic veins rather than the usual course of starting in the distal veins and then extending to the proximal veins and then going to the heart. And also in the patients with the IV catheters. So look for the source of thromboembolism in uncommon places in the patients who are having and these IV catheters are who are pregnant in the pelvic veins and the upper extremity veins. Let's move towards how it actually propagates. So what happens is that they arise in your veins here, they go to your right heart, and from the right heart they go to they break off, okay, in the right heart into multiple thrombi and goes into the pulmonary circulation, obstructing the parts of the pulmonary artery, and it results in increased alveolar dead space, vascular constriction, and increased resistance of the blood flow. So that's actually what is the pathophysiology involved. So from vein to the right heart, okay, and from the right heart they go to the lung and obstruct over here. Now the next thing is talking about the patients who are actually at the high risk. So any of the patient who is with the recent surgery, especially the orthopedic surgeries, the patient who have cancer history, particularly the prostate, pelvic, abdominal, and breast cancers, immobile patients, especially those who are mobilized, pregnant ladies, and acquired and inherited thrombophilias. Acquired thrombophilias like lupus anticoagulant, nephrotic syndrome. So in the nephrotic syndrome, actually, there's a loss of antithrombin 3. So that is a procoagulant state. In inherited thrombophilias, if we talk about, then there is a factor V laden mutation, protein C, protein S deficiency, antithrombin 3 deficiency. Now, the symptoms, let's talk about the symptoms here. So the patient, they present with the sudden onset of the dyspnea and tachypnea. There could be the thigh or the cough swelling over there, pleuritic chest pain, hemoptysis. Actually, hemoptysis occurs only in with the infarction, and the tachycardia. These are actually the common presentation the patient comes with. Um, the next thing we're going to discuss over here is that how you're going to treat, investigate these patients. So there's two level PE well score. So this is what you need to calculate. Okay, you can find this algorithm anywhere on the internet. So if that score is greater than 4, if the two level PE is greater than 4, this means there is high probability of the PE. So go for the CTPA. And if that is delayed, give anticoagulation. If you have that facility, again, you can do that immediately. You can do that. Otherwise, a very good thing is to give the anticoagulation and send for the CTPA. So now, say for example, if the CTPA is negative, then what you're gonna do? Then you can go for duplex ultrasound of the legs, okay? Because as we have discussed, that this arises from the deep veins above the knee, and actually it comes from below the knee and then to the above knee, and then from the inferior vena cava to the right heart. So if high probability, straight go for CTPA, give anticoagulation. If negative, do the ultrasound. If ultrasound comes negative over here, this means that everything is okay. Even you need to stop the anticoagulation over there. If the PE, two-level PE well score is equal to or less than 4, so go for the D dimer first. If that is positive, go for the CTPA. Give anticoagulation and go for. Whenever you are sending a patient for the CTPA, it takes time. Okay, so better is to give the interim anticoagulation. That is an important thing to do. And say, for example, here the P2 level PE well score was less than 4. You did D dimer, they were positive. That is followed by CTPA. If the CTPA comes negative over here, stop the anticoagulation. Okay, you need not to worry. Stop the anticoagulation if the CTPA is negative. So this is how you're going to do. So anticoagulation is over here. So I'm going to summarize that. Two-level PE well score, if it's greater than 4, CTPA. Give anticoagulation, CTPA. If that's negative, go for ultrasound, Doppler ultrasound. If that's negative, stop the anticoagulation, no issues. If the two-level PE well score is equal to or less than 4, go for D dimers. If they are positive, go for CTPA. Give anticoagulation, go for CTPA. If the CTPA is negative, stop the anticoagulation. Now, the problem over here is that, say for example, if the anticoagulations are contraindicated, then what you're going to do? Then it depends on whether the patient is stable or not. If the patient is stable, then go for IVC filters, because here you cannot give the anticoagulation. As we said, it's contraindicated. And if the patient is unstable, okay, then here you need to give a patient thrombolytic therapy. This is not particularly that has got to do with the anticoagulation contraindication. If a patient with the pulmonary embolism comes with he's hemodynamically unstable, you need not to give the anticoagulation. He's a candidate for thrombolytic actually, and not the anticoagulation. Okay, so it's a thrombolytic therapy. As if the thrombolytics are contraindicated in a patient who is unstable, okay, then go for embolectomy. You can go for embolectomy and um, yeah, that the embolectomy you need to go for that.